them, but it has all the ones I would test you over. So there's some of the older products in the 1A class, which are quinidine and procainamide, are not used as much anymore. So this has all the pertinent ones in it. Then I took, you had Corey Wadley this morning?
Yeah.
So from her presentation last year, I put together a table of all the indications. So that's this one. And then we've got the drugs for today. So mostly we're going to look at the drugs and what they do and their side effects, because they are significant and there are many. So if you are in a clinic that is going to start these, you will certainly see these show up in general practice. So it's a good thing to know about them, because some of them have side effects that begin early in treatment, but many of them show up later in treatment as well. Some of them are life-threatening, some of them are just annoying. So being aware of those, I think, is important, especially if you're in primary care practice. Mostly I'm going to focus on adults and not ones in children. So let's just kind of get our minds back in and review. So in terms of electrical pathways, where does everything start? Assay node. And it is in what chamber? Okay, and from there it goes where? Well, it goes over the other atrium. So all the atrium is coordinated, right? Then AV node, and then where? Okay, and then where? Purkinje fibers, okay. And then we get muscle contraction of the ventricles and ejection of blood. Okay, very good. So the heart, these fibers have a very different type of action potential compared to nerve fibers. They have a very long plateau in the second phase, and then they have a much longer repolarization phase and threshold. So a muscle cell, the nerve cells here have about a 300 millisecond cycle. Nerve cells have a 1 millisecond cycle, so it's very different. And that is so you can coordinate excitation with contraction, right? So how do we get from that nerve impulse to the heart beating? You've got to translate what's going on in the nerve to the muscle. So where does that happen? What part of the phase? What would the muscle excitation be? No? Okay. So what's the purpose of that action potential?
To make the cell more positive.
Well, it's to send a message to the muscle cells that it's time to contract, and we're going to contract in a coordinated fashion, right? Mm-hmm. Okay. So how does that get translated? Where does that occur? What do muscles have to have in order to contract? Calcium. So where is calcium mostly in this action potential?
Phase 2.
Okay, so they're in there. So calcium, when that happens, when there's a stimulation, there's a neuronal stimulation of calcium, what happens then to the muscle cell?
Contract.
Okay, well, in between that.
Your calcium.
You get calcium released, right? What's a sarcolemma?
Oh, that's the membrane.
So you have a membrane around a myocyte, right? And it releases calcium. That, in turn, causes a calcium release that the muscle can use. So it's almost a calcium-stimulated calcium release. Okay? And calcium enters, and that's when you get, it interacts with what protein? Troponin. Okay, that troponin and calcium, plus you've got phosphorylated, we talked about this yesterday, myosin, right? That can then interact with the actin, cause cross bridges. That sarcomere shortens, right? Contraction successful, calcium levels go down, muscle relaxes, we start all over again. Okay? All right. How do we get coordination with all of those muscle cells? Why can they? You have gap junctions. So gap junctions are what? Yeah, they're like holes. So they allow those cells to communicate very quickly. So whatever happens to one happens to all of them. And so we have a very coordinated subtraction. Okay. Very complex, and it works. So the one thing we have with that resting, with this membrane is what maintains this? Talk about thresholds. What's the difference between the inside of the cell and the outside of the cell? So where's the sodium? Mostly. It's just outside. Where's the potassium? Okay. Can the cell do this passively? No, it takes energy. Because what do those ions want to do? They want to move across, they want to equalize, right? Okay, so the cell has pumps that constantly keep that gradient at a difference. Okay. So it keeps potassium intracellularly and sodium extracellularly. So in order to do that, we get that resting membrane potential difference, right? Okay. So then when you've got a slow sodium leak, right, until you get to a point that we call this what? Threshold. And then what happens?
Full depolarization.
You get depolarization, right? Okay. What does that mean?
So it gets more positive.
The cells become more positive. So we move to equilibrium, right? We move to almost zero, which meaning the concentrations are similar. And then what's this little thing up here? The overshoot? Overshoot. What phase is that?
Phase 1, 2.
Phase 1. Okay. This is phase 2. What's happening to potassium in all this?
It's going down in phase 2.
So in calcium's coming in, potassium, is it coming in, going out?
It's going down.
What's happened, what do we call this phase?
Phase 3.
Repolarization. And that's phase 3, right?
Yes.
And then we get to phase 4 and it starts all over again? Yeah. Okay. All right, that's good. So the drugs all take advantage of that. These drugs will, as a class, will each target one of those phases, usually. Sometimes they'll target more than one. So if you look on, we've got most of them running. So there's your action potential. You've got that rapid depolarization. It's very fast because it's a huge change over a very short period of time. So the speed or the velocity of that vector is fast, very rapid. Okay, then you get some sodium is exiting again. You've got some potassium and calcium are being exchanged. So you have these pumps that are usually exchanging so many calcium for so many potassium. And then that stays steady. That's where your contractions are taking place. What does that relate to on the EKG? QRS. You have repolarization. You go back to baseline again. Okay. The next little picture that I have, these are just reminders. So Purkinje fibers, SA node, very different. SA node is very much more unstable in terms of how it performs and thresholds. We're not going to worry about it. We're looking mostly at Purkinje fibers when we are talking about most of our drugs. And that shows you at each phase what is the major electrolyte that's moving. So good review. Go back over that. I assume you talked about this in physiology, right? Okay, so just trying to get your brain back to it. So the antiarrhythmic drugs, I'm on page 4, middle of the page. There's an old classification of antiarrhythmics called the Vaughan-Williams classification. If you look at the I think it's on the very last page 25, there's a chart with that classification. This is an old classification. There's been a call to get rid of it. Mostly it is based around the drug's action. That's where the 4 classes come. So a lot of calls to reclassify these antiarrhythmics. But it stays in the jargon and most people are in the conversation. So I think it's still good to at least know it and to understand how they've organized it. So if they talk about a class 3, even though they've tried to get rid of it, they really haven't come up with anything better. So you'll still see, you'll read, yeah, the treatment of this is a class 3 antiarrhythmic. So you need to know which falls into that. Okay. So we're going to approach it that way. But probably in your lifetime it'll change because others will come along and we'll get a little bit better at figuring out how to classify them. So class 1. What do you notice with class 1? Where's the big change? Phase 1. Okay, so these drugs mostly affect sodium channels. There are this class is broken down into 3 categories: 1A, 1B, 1C. So let's start with 1A. These are probably the oldest of the antiarrhythmics. This is quinidine, procainamide, and disopyramide. These are very good at suppressing tachycardias, reentry type of arrhythmias. They also affect the effective refractory period. So let's start up on the page 5. Let's look at 1As. There they are, quinidine, procainamide, disopyramide. Quinidine and procainamide have a lot of problems associated with them in terms of adverse effects. So they're not used very often anymore. They're still around. You may come across folks. Disopyramide of this class, disopyramide is used more frequently. So sodium channel blockers for the most part, potassium to a minor degree. So they slow down conduction velocity. So you can see why they're good in certain arrhythmias. They prolong the refractoriness. So re-entry and trying to get back in quickly, they slow that down because if a arrhythmia or a action potential tries to come through too early, they will find the tissue refractory. What do we mean by that? It just won't be polarized. So that can be a good thing. They're very broad spectrum, so they can be used against a variety of arrhythmias. You might want to keep that chart beside you as we're going through. So let's look at disopyramide. Morpace is the brand name underneath. Indications, so you see atrial arrhythmias and also life-threatening ventricular arrhythmias. Contraindications are thrombocytopenia, because they will affect it and decrease it. Greater than first-degree AV block, so second and third. Why does it say concurrent use of quinolone antibiotics? Because they prolong QT interval. What other drugs do you know now that prolong QT interval that you need to be careful then with? Macrolides and what else? What antiemetic? Zofran, placed in your brain. Those are the ones that prolong QT interval. Monitoring parameters would be EKG, blood pressure, and anticholinergic effects. So this drug has lots of anticholinergic effects. So what are they?
Slud.
No, not slud. Anti-slud.
Oh, right.
Okay. Anti-salivation, lacrimation, urination, defecation. So, dry mouth. So mental, remember that those anticholinergics are on the Beers list because they increase the risk of dementia. Okay, so that's where the confusion, that's what it's referring to. Constipation and urinary retention. All right. These drugs have to be dosed around the clock. They're very short actors. So we usually use serum concentrations to monitor them and adjust therapy and change dosing. They are renally eliminated, so we have to adjust when you get into people who have renal insufficiency. So often in the handout, what I'll do is I'll tell you what's the most common side effects and then what's the most serious. So here the most serious is hypotension and heart failure. So this drug has a significant negative inotropic effect. So in someone who is at risk, it can precipitate heart failure in somebody who is already known to have heart failure, or it can precipitate new onset. So remember the little formula there, blood pressure, cardiac output times total peripheral resistance. So hypotension and cardiac heart failure. Next page, most common are the anticholinergic. We've gone through those. You can see dry mouth is one of the most common. So what do you do for dry mouth?
Biotine.
So okay, we'll tell them what biotine is.
A dry mouth mouthwash.
It's a dry mouth mouthwash, that's exactly right. So why do we worry about dry mouth? Why are you going to listen to a patient's complaint about dry mouth?
You don't have saliva, the bacteria in your mouth.
So it increases the risk of dental caries. So good mouth hygiene is important. What else?
Halitosis.
Halitosis makes the breath smell bad. And people don't like it. It also, your mouth can get so dry, it will interfere with your ability to talk if it's really that dry. So using the biotine, you can have them, as long as they're not fluid restricted in any way, so ice chips, they can use non-sugar candies, but you have to worry that you have to limit those because the sugar alcohols that they put in there can give them a lot of GI upset and diarrhea. So working with patients about how to work with dry mouth is important. We will hear this word over and over again, is pro-arrhythmic potential. And if you look, I don't think I put a chart. I think I just put text. I think I took that table out. I did. So we'll go over and over this again. So pro-arrhythmic means that it can create a situation in the heart where it's more likely to produce an arrhythmia, and usually they are not good. Usually they are malignant arrhythmias. Okay? Torsade would be the worst of those. VFib, the worst of those. Okay? So we're always going to be keeping an eye out for that. You will see black box warnings on almost all of these drugs because they are pro-arrhythmic. Increase in death, excess mortality. So again, it becomes very much a weighing of benefit versus risk. Two of the things, and I didn't put it here, but throughout, the two things that really put people at risk for these pro-arrhythmias are low potassium and low magnesium. Now, there's no recommendation that says you need to put them on a magnesium supplement, but I think that is something to consider. Potassium, you need to look at, are you depleting them of potassium and not replacing it? So if they're on a diuretic, which a lot of these folks would be, making sure that they've got, they have a potassium supplement if needed, and they're taking it. So potassium salts are not always very good on the stomach. Sometimes they're very upsetting, and so sometimes people don't take them. So it's important for them to be on one and to know the importance of taking them. And then also looking at that magnesium. Remember, we've talked about before that it is hard to correct a significant hypokalemia if they're also hypomagnesemia. So don't forget about that, that cation. All right. So you'll see here, there's the picture of that widened QT interval with these agents. Oh, I did put there calcium and magnesium. They're also susceptible to 3A4 inhibitors. So I'd say with a lot of the antiarrhythmics, you'll see this, amiodarone's the worst offender, is that anytime you are adding a drug to somebody who is on an antiarrhythmic, look up the interactions. When we get to amiodarone, there's 3 or 4 of them that are so major, I want you to know those. But the rest of the time, just look it up, look it up, look it up. Questions about that one? There's the black box warning. Risk of excessive mortality and non-fatal cardiac arrest, so non-fatal MI. Okay, so class 2B. So what do you see there? It changes repolarization, so the effective refractory period is shortened. So what happened to the QT interval? It goes down, shortens. Okay. So the drugs in here are lidocaine, mexiletine, phenytoin. I'm just going to address the first two. Or lidocaine and mexiletine. They're fairly similar. They decrease conduction velocity. They decrease the refractory period. Decrease automaticity. So if you look on your chart, where do you see that they mostly fall? Mostly ventricular arrhythmias. Okay. Moving on to page 7. The other thing I did in your handout is because there's just so many side effects, is I gave you pictures to kind of, if you're a visual person, look at, so you got pictures that also represent the major grouping of those side effects. So acute treatment of ventricular arrhythmia from MI, cardiac manipulation. It's an old drug, lidocaine's been around a long time. It's given IV, there's no oral form. The canes don't stand up to stomach acid very well, so they're degraded. Contraindications would be heart block or Wolff-Parkinson-White syndrome. Did you talk about that? Okay, what is Wolff-Parkinson-White? It's a pre-excitation what? I can't hear. One person say it. Pre-excitation what? Syndrome. Okay. So what's that mean?
The signals go around the AV nerve. It's like a new pathway.
It's a okay. Who does there? Can you get it? Can you develop it at 40 or 50? Usually you're born with it. It's genetic, so they usually will show up early. So pre-excitation. So what kinds of things do you think they would exhibit? Syncope. Okay. So what do we do with those? They ablation. They ablate them. Okay. Very good. So monitoring parameters, liver function tests. Really important. And you'll see this with a lot of the drugs is liver function. You can monitor serum levels. Most of the time we don't do it because we don't use the drug very long. But if you're going to use it for more than a day, then you would probably get lidocaine levels in order to adjust and avoid toxicity. Most common is central nervous system toxicity. Wide range, change in mental status. So it can be anywhere from mostly depression, or they can hallucinate, see things that aren't there, visual hallucinations, nystagmus, slurred speech, memory impairment, tremor. Cardiovascular toxicity is not very common. So you can see decreased heart rate up to asystole, so another reason why the AV block is a contraindication. GI is significant with the nausea, vomiting, and anorexia. Usually isn't so much a problem because we don't tend to use it for very long. It's more of an acute antiarrhythmic. Let's look at mixilotine. Very similar to lidocaine, it's available orally. Again, for ventricular arrhythmias, works on those sodium channels. Decreases effective refractory period for Purkinje fibers, which is most of what we're looking at. Does not slow conduction to the AV node, so it doesn't have the problems that lidocaine has with its effect on AV node. Doesn't prolong QRS complex or repolarization. It's indicated for life-threatening arrhythmias. It is a tough drug to use. It has lots of side effects that can be lethal, and you see down there under the black box warning, potential risk of excessive mortality, non-fatal cardiac arrest, potential risk for acute liver injury, like we saw with lidocaine. So LFTs with the 1Bs. Most common side effects, GI, CNS. GI, because it's taken orally. It's part of the problem. So we advise people if they're on it, to take it with a meal. CNS, you see very similar to what you saw with lidocaine. Dizziness, lightheadedness, tremors, nervous, coordination changes, sleeps, paresthesias, numbness. Cardiovascular, heart failure, and hypotension has an odd little skin reaction that it will can cause. This is a mixilotine-induced hypersensitivity, usually face and trunk. Can occur long, but they can be on it for a long time before they develop. This man actually developed it after 5 months. So they can be on it for a while before this shows up. Pro-arrhythmic activity, so it can induce fatal or malignant arrhythmias to a lesser extent than lidocaine, but still is a problematic. So we don't use it for minor or asymptomatic arrhythmias, like PV6. Questions about those?
I have a quick question.
Here's your little pictures as reminders. Yes?
Are these mostly administered under care, like inpatient?
Oh, good. Yes, I do have a list. Some of these are started inpatient. Some of them have manufacturer recommended. So like when we get to Sotalol, you'll see it's recommended only be started in the hospital, or dose changes are only in the hospital. And then some of them can be started on an outpatient basis. So I've given you a list a little bit later in the, taken all of them that we talk about, put them into, categorize them that way. Good question though. After you see the side effects and the warnings, that would be a normal reaction. I'm only starting this in the hospital. Okay, the 1Cs. Okay, so what do you see there? These are the most potent in terms of changing depolarization compared to the 1As even. So there you see a significant change in the QRS. Two in this category, there's flecainide and propafenone. They greatly slow conduction velocity, they don't affect the refractory period, decrease automaticity.
Dr. Letassy, what is automatic? I don't think I understand that.
What is automaticity?
Like how?
What's automatic in the heart? So rate.
The rate.
Rate.
So it's
Rate and conduction rate.
just as all.
Mostly rate. Well, like SA node would be part of it.
So just the automatic beat of those.
Yes.
Okay.
So flecainide. Flecainide is AFib, flutter, prevention. You'll see all these prevention. This is an oral agent. Paroxysmal SVTs, ventricular arrhythmics. So flecainide has a lot of use. It's fairly broad in its application. Again, we're going to not use it when we get into AV node blocks because it will worsen it. Right bundle branch block. Ritonavir is a drug that we use with patients who have HIV. Okay, so here you go, Ryan. Usually start this one in the hospital. Can be started as outpatient for AFib, but the rest of them in-house. Liver function test, so we've seen that again. Of course, EKG, their blood pressure, LFTs, here's, again for the liver, serum concentrations. So why do we draw serum concentrations? What does that tell us? Why do we draw serum concentrations of drugs?
See how much free drug is in the blood?
I think you got it, I just can't always decipher the all the voices. So serum concentrations are drawn. Call this the trough. What would that be? This is the peak. This is therapeutic range. So serum concentrations are helpful when the concentration of drug in the blood correlates to a clinical effect. Okay. So if we say this drug, making it up, when it's between 1 and 4 milligrams per deciliter in the blood, we get the best effect on the heart. We get the best antiarrhythmic effect. Okay. Troughs are the lowest point in that range, and peaks are the highest. Okay. If we get below here, we get subclinical effects, so we don't get as good of an effect as we want. Okay. Peaks, if we go above that, then usually we get into toxicity. Okay. So that's why we don't draw them on all drugs, do we? Do I sit up here and tell you most drugs we draw? No, we don't. So this is one of the drugs that it helps. Because if the patient lives down here, they're not going to get the effect. If they do this, they spend part of the time below the trough, part of the time above the peak, they'll get side effects much more often or subclinical therapeutic failure. So what we do here is we usually change up the dosing interval. So we can tighten the interval so that it doesn't have as long to fall down below here. And if we spread it out, the peak usually will fall below where we want it. Okay? That's why we do therapeutic drug monitoring. Okay. So there's that black box warning again. Excessive mortality or non-fatal cardiac arrest seen in patients treated with flecainide compared to placebo. So a very pro-arrhythmic drug. Causes lots of malignant arrhythmias. Conduction abnormalities are listed. We've talked about most of them. It prolongs that PR interval. So what is that? What's the PR interval? P is atrium. What's the R? PR.
From atrium to ventricle.
You're moving through the signals are moving through and then past the AV node. Okay, so if you look up there, you see AV node conduction delays. So that should make sense. PR interval widens, AV conduction slows. What do we call that effect on the AV node? What's a drug that has AV that has effects on the AV node? We say what kind of effect is that? Dromotropic. I always think about camels. You know dromedaries?
Camel ride.
What's a dromedary, okay.
Single hump versus the one with the bead.
Single hump versus a right.
How much Discovery Channel?
Right, who was time Caitlin?
I won't confuse you. Okay, so dromotropic effects, if we affect the rate, heart rate, what's that called? Chronotropic. If we affect contractility, what's that called? Inotropic. Then they've got another one, lusotropy. What's that one? That's relaxation, cardiac relaxation. Okay. So chronotropic, dronotropic, inotropic. Learn those words because you'll see them often. No effect on QT interval. Okay, so hemodynamic, it's a negative inotrope. So so if you see negative inotrope, what do you start thinking? Heart failure. See this little fellow down here? He's worn out. Okay, so negative inotropes decrease contractility. So in people who are vulnerable, then they can develop heart failure. What does heart failure mean? You can't.
Pump enough blood out.
It's kind of like football compared to soccer ball. You can push like a football in, you can't push like a soccer ball in as much. Cardiac output. Wait,
Works for you? Okay. You stay with it. Okay, heart failure, so it's one of your definitions. So the heart cannot push enough blood through to meet the demands, the tissue demands of the body. The volume that you present, it cannot handle. So what's the first thing that happens then? Where's it back up to? The lungs. Okay, it's pulmonary congestion. Okay. You haven't done heart failure yet, have you? Extracardiac events. So 10 to 20%. I told you anything above 5% is significant. In pharmacy world, we consider that a high rate of adverse effects. So your hemodynamics are high, and your extracardiac. So dizziness, blurred vision, headache, nausea are the common ones. Neurotoxicity. So if you don't adjust the dose in somebody who has renal insufficiency, what happens? What does that matter? Drug is cleared by the kidneys. People their kidneys don't work as much. So you can't eliminate it, so it stays around longer. So it's around longer to exert a pharmacodynamic effect. Okay? All right. All right. So under neurotoxicity, you see common are the dizziness and the visual changes, but rare are the psychosis, hallucination, and seizures. Okay, propofenone, rhythmol, indicated for life-threatening ventricular arrhythmias. So, due to safety risks, look at the ones it's reserved for. Symptomatic SVTs, AV nodal reentrant tachycardias, AV reentrant, did I put that twice? No, I didn't. And
Is there a difference between re-entry?
I don't know.
Oh.
I wrote it down, now I don't know. And focal atrial tachycardia. Mechanism, again, it's that fast sodium current. It does have beta blocking activity. Okay. So if you look back at its side effects, that's where that comes from. That negative inotropic effect is due to its beta blocking abilities. Also, its calcium channel blocking activities. So some calcium channels blockers are also negative inotropes. So that's where that comes from. So if you can link those two and remember, it will help you remember that side effect. we're going to see when we get to the next class of drugs that they often have multiple properties. Beta blocking, calcium channel blocking, sodium and potassium channel blocking. Okay? So if you can start to remember, then take it the next step as to what is most likely going to cause the person trouble. Contraindications, sinus, and that's, stop and back up. That's why, one of the reasons why they want to do away with that bond, this classification, is because people or group drugs in the group have multiple different properties, so they all don't look the same. So that's one of the reasons they want to realign them. Aren't you glad you know that now?
Yes.
Yes. Next is yes. Okay. Contraindications, sinus bradycardia. Got that beta blocker, so it's going to slow down heart rate, right? Beta blockers slow heart rate, so you can see why the contraindication comes about. Uncompensated heart failure, beta blocker. Significant hypotension, beta blocker, calcium channel blockers, both have effects on heart and peripheral resistance. Reactive airway disease, beta blocking property. Uncorrected electrolyte abnormalities. So I think they're probably talking about potassium and magnesium. So orally, same monitoring, EKG, blood pressure, pulse. Adverse effects, here's the black box, increased mortality with non-life-threatening ventricular arrhythmias. So common common side effects are the GI, CNS, cardiovascular, so lots of things here. So GI, so it has some unusual ones. Patients complain of taste disturbance. What do we call that? What's the medical term for it? Dysgeusia. 20%, so that's pretty high. So metallic, salt, doesn't taste good. Notices it's a perceptual change in the way foods taste. Nausea, here's liver toxicity. Recommend they take it with food. CNS, dizziness, nausea, blurred vision, similar to what we've seen with the other in that one, class 1. Cardiovascular, negative inotrope, there it is. Bradycardia, slow AV conduction. So what's going to happen to the PR interval? Beta blockers always prolong that PR interval. What's a normal PR interval? So you can see it up to, beta blockers will often move it out to about 200 milliseconds. You're saying it's 120? The beta blockers will do that. Okay. Questions about that's the ones. Class 1. Class 2 you've got some familiarity with. So here's the drugs again. Okay? You're going to hear beta blockers again when you talk, when Dr. Britton talks. You're going to hear it again when we talk about heart failure. So thank goodness these drugs have multiple uses. So class 2. Well, let's break since we're going to start a new group. Let's break and we'll come back a couple of minutes after 2. Yeah. Chronotropic is break, mostly assay Chronotropic is the conduction through the AV node. SA node is rate. SA node is the pacemaker. It starts everything. Right. You're going to be able to AV, so drugs can block, calcium channel blockers, beta blockers can block the AV node. So we take advantage of that when we get to AFib, so we can control the ventricular rate by controlling how fast. It's a different tissue. So when that conduction hits that tissue, it's a different. So how fast it travels through there will determine ventricular rate. Well, conduction is once that pacemaker starts, a potential action it just runs through the electrical system, but when it gets to that AV node,
No, I was saying, I just looked
junction,
up
there
our
is a
notes
change
on
in
doc,
the tissue, and so
to
it
see
changes the
if,
rate at which it goes
like,
through.
remember?
Then it
Headache,
hits
like,
the,
any of my
right, then it
symptoms
hits
are on
the
there, and they're not.
Purkinje,
Because my doctor replied and said there's no other drug they could switch me to.
bundles, and
She was like,
then
it wasn't a
travels
doctor,
at
it was a
different
nurse.
speed.
And she
So
said,
that
Dr.
AV
Trevor
node
said there's no
is
alternative.
a source of disease.
Like, I feel
It's a
fine
source
now,
of
so maybe I should just take it really early and really late, so
pharmacological.
it doesn't affect me.
That's dromatropin.
Temporary.
Dromatropin.
I still
Yeah,
make it worse. But she's like, maybe we'll switch you to capsules, but I'm already
Do
taking
your other
capsules.
lecturers not use those terms?
They have a little bit.
There may be.
I have no training for
Yeah, I'm already taking capsules.
Maybe just,
I think
Yeah,
drug
I would
people.
like to take it. It doesn't make sense.
but we didn't set all behind.
Right.
All right. Hard stuff.
Like if I get somewhere in the morning, then it's like the worst. Like, I'm super tired at looking at it. When I think about it, but yeah, I made it out. You know, like coverage people. Yeah. But she said she understands.
Okay, so I don't understand what the fuck
It's
is
like that
this
picture
thing.
of that.
I was gonna look 1 and 2 together since this is the part you're talking.
No, you're good. Hold on, I'm almost done.
Left her car in and Bill wasn't in.
I hate writing
I know.
any word that has a rhythmic in it. I can't, like, I spell it.
I know, that's how I feel.
Same.
She just said they'd replied to my
I do. I hate arrhythmic,
And then she's like, well, maybe
diarrhea,
you
and
can try
hemorrhage.
capsules.
Those are my bad words.
I'm going to, and I don't want to.
Also, I have trouble with icosanoid, but that's its own case.
Like the pseudotumor cerebral hemolytic. It was just a GI and the depolarization and I took it
I know the feeling.
at the time, so.
Yeah, but during that time, you were very uncomfortable.
I know. It's like for like 30, 45 minutes.
Yeah.
And I said, I replied to him, I know capsules, I guess I'll just have to fix my timing. So it's earlier and later, I mean, I'm talking 12 hours.
Yeah, it's annoying.
I mean, I get that there's certain types of bacteria you have to kill with certain antibiotics, I understand that, but.
Yeah, but you're literally having an wrap.
As I was like, I just want to make sure it's not serious, like.
Yeah.
I think I could be
Well,
Okay. So my 3 is your 4. I think is the problem because I combined 1 and 2 together. So it was like
yeah, I did too.
right?
I did too.
Yeah, it was fun. I didn't
And then 3 adverse reaction.
No.
See, my 3 is this.
Yeah.
I deleted 1 and just like add it where it was the same paragraph.
Oh,
That's why I think.
yeah, I did adverse reactions here, and then here, medication, measurement, drug interaction.
This is the one that
I didn't do that appropriate change in therapy to avoid toxicity. What does that mean?
Yeah, I don't know. That's why I was confused. That's why I thought it was something to do with concentration, but I guess not.
I think I'll be good.
It was medication.
I mean, my schedule.
Do I?
But I'm so busy, actually, it'll happen. I don't like it. You know. Yeah, so I like the
Too much.
I don't like doing it, but it just saves me so much time.
Yeah, it was really fun.
Okay, I just deleted my 3 because that's pointless.
Oh, that's all I'm doing.
I don't even know right now. I need to find something to do.
So like
So I really have to, I cannot eat rest
About hummus. I don't know what you can't
I
eat,
do
but
that on test days.
like when you're studying in the morning.
Yeah, because I study
That's all
college, and I like college, how like I can continue to study off of sleeping.
Yeah, I never do that.
It's weird.
Save money. Save money.
I like your shirt too. I mean, I like your shirt, Taylor. No.
Cool.